Bismillahirrahmanirrahim. My name is Dr. Muad Abdullah, and myself and my colleague Dr. Ahmed Saleh will be giving a talk on the clinical management of inpatients with COVID-19. This disease is also known by two other names, coronavirus in general layman terms, and also the official name of the virus, which is SARS-CoV-2. Although the World Health Organization recommends the use of COVID-19 more generally to avoid confusion with the previous SARS infection in 2003. So given our experiences working in a hospital in the UK, managing patients with COVID-19 in the last 2 to 3 months, we thought we'd put together a talk covering 4 main subjects. The first being how the virus is transmitted and how it enters the human body. Secondly, what organ systems have found to be involved. And thirdly, what the general management is of inpatients. And we'll be covering everything except intensive care management. And also a few other important considerations, such as cardiopulmonary resuscitation in the age of COVID-19, and also the current testing capabilities available to us at the moment. It's important to note that COVID-19 is an RNA virus and is primarily transmitted by the respiratory tract, by respiratory droplets, which can be suspended in the air when someone coughs or sneezes, and also by tiny molecules which can also be suspended in the air. And in one study in the New England Journal of Medicine, it was found that the virus could last for up to 3 hours in the air, although this was an experimental study and has not yet been replicated in real life. And more worryingly is that the virus can also last for up to 3 days on surfaces, in particular metals and plastics. Hygiene and thorough cleaning is important on a regular basis. So the COVID-19 virus enters the body and then enters cells through the ACE2 receptor, which is located on the surface of cells, and then enters the cell and replicates. And in addition to the lungs, which is the primary area of infection, the ACE2 receptor is also highly expressed in the human heart, in blood vessels, and also the GI tract, which makes sense when you think about the symptoms and signs that patients commonly present with. With regards to risk factors for developing more severe disease, it's now common knowledge that the elderly are worst affected by COVID-19, and these tend to be patients who are more than 65 years old. However, there have been patients who have been severely ill in their 20s and 30s. In addition, having a history of cardiovascular disease such as ischemic heart disease or heart failure can also put you at increased risk, as well as lung disease such as a history of COPD or asthma. And having a typical metabolic type picture, so metabolic syndrome type picture, can also increase your risk of significant disease. In addition, having significant medical issues such as end-stage renal failure and chronic liver disease, as well as other conditions that suppress your immune system or being on immunosuppressants, are also known risk factors for more severe disease. So as mentioned, the ACE2 receptor is present in the respiratory tract, but also present in the GI tract and also in blood vessels. And we'll go through those systems and how it can present in those organ systems. Starting with the most common clinical presentation, which is the respiratory tract. So COVID-19 typically causes a flu-like illness with cough, high fever, often very high fever, sometimes in 39 to 40 degrees. Patients can also have muscle aches or myalgia, as well as sore throat and a pounding headache. And these can be considered the flu-like symptoms. However, a patient can also then subsequently develop shortness of breath, which is the most worrying symptom or sign. So up to this point, in the majority of cases without any shortness of breath, they can, on the whole, usually be classified as mild illness. However, if they do develop shortness of breath and hypoxia, then this would be classified as at least moderate, if not severe illness. And if this happens, then at the very least, the patient requires a review by a medical professional with consideration to whether this patient will need admission to hospital and oxygen therapy. And the majority of patients in our experience who presented to hospital presented because of shortness of breath. My colleague Dr. Ahmed Saleh will cover the ins and outs of oxygenation in inpatients and also non-invasive ventilation, and what other techniques can be used to help patients with this disease. So we've covered the most common ways that patients present, and this is with respiratory symptoms or typical flu-like symptoms. The next, probably most common way that patients also present is with GI symptoms as well, and these can occur in combination with respiratory symptoms. In one study in China, 61% of patients had a GI manifestation of COVID-19 as well as respiratory symptoms. And the most common one of these was deranged LFTs. And this typically caused a rise in ALT of 2 to 300. Next most common was diarrhea, and this occurred in just over 10% of patients. And we've also seen patients admitted to hospital with abdominal pain and vomiting. It's important to note that patients can also present with GI symptoms without any respiratory involvement whatsoever. I think in one study, 1/3 of patients had GI symptoms only. However, having both respiratory and GI symptoms, which is the majority of cases, is known to also be a risk factor for more severe disease progression. So moving on to the effects on the cardiovascular system. As with the SARS virus and the MERS virus, COVID-19 also increases the risk of myocarditis and arrhythmias, and can also cause acute coronary syndromes and exacerbate existing heart failure. And myocarditis can be detected with troponin and ECG findings, and arrhythmias should be thoroughly evaluated on admission. For example, if someone presents with a prolonged QTC, some of the medications given during inpatient stays, such as clarithromycin or azithromycin, can also prolong the QTC and should therefore be avoided. There have also been patients presenting with neurological manifestations of COVID-19, and in a recent study in America published in the New England Journal of Medicine, 5 patients who were less than 50 presented with COVID-19 symptoms, which are known about, as well as a stroke. And 2 of the patients were less than 40 and had no risk factors for stroke. In addition, there have also been a few case reports of patients presenting with encephalitis with no other suspected cause. Another quite common symptom is a loss of the sense of smell or taste, and this can often be the only symptom in some patients. And if patients develop anosmia, even in isolation, these patients are likely to be infected with COVID-19 and are at risk of transmitting the virus to others, at least in the first week or so. COVID-19 can also affect patients' renal system, and in the majority of patients there is no reported acute kidney injury. However, renal failure most commonly occurs in patients who are most unwell and admitted to intensive care. And so overall, approximately 1 in every 200 cases can also develop an acute kidney injury. And this is similar to what caused AKI and sepsis, i.e. a severe inflammatory response, hypotension, fever, and insensible losses. And also, COVID-19 is known to exacerbate chronic kidney disease. In the last month, there has also been a review carried out in Spain, which is published in the British Journal of Dermatology, and they found that there were 5 distinct skin lesions which were associated with COVID-19. And I'll just go through them briefly as well. So the first one, as you can see here, is what's known as a pseudo-chilblain, where the patients develop erythema in the digits of the fingers and toes. And when this occurs, this is often in children or in mild cases of COVID-19. Patients can also develop vesicles, as shown in the picture here. Raised areas on the skin, typical of urticaria, were also seen quite commonly. Here you can see a maculopapular rash, which was also seen quite often in COVID-19 patients. And finally, the fifth listed skin condition that was quite commonly seen in Spain was this typical purplish skin lesion known as livido or necrosis. And when this occurs, this was often in the most unwell patients or the patients who had the most severe disease, and also occurred most often in the elderly. So when patients present to hospital, all of them have blood tests, ECG, chest X-ray, and a COVID-19 swab for PCR. If after evaluation and monitoring their oxygen levels, it's deemed that they are safe to go home, then our usual practice is to discharge them with oral antibiotics, just to cover for possible complication of pneumonia. And in patients who are admitted, they're given broad-spectrum IV antibiotics, intravenous antibiotics, alongside atypical cover such as doxycycline and clarithromycin. And although some international guidelines say that only patients with clear secondary bacterial infection should receive antibiotics for a short period of time, in reality it can be a lot more difficult to differentiate who has this purely viral disease and who's developed the complication of pneumonia. So two other considerations for inpatients are fluid balance. Initially, it was thought that patients should be in a dry state as much as is possible as per the management of ARDS. However, this has been shown to have poor or worse outcomes in COVID-19 patients. And so the aim now is to maintain patients in a euvolemic state with IV fluids if required. And it's quite common to give these patients IV fluids because of fevers and significantly reduced appetite. And the other quite common presentation of some patients is with a PE or a DVT. And unless there is a contraindication, all patients should receive prophylactic subcutaneous heparin. In one study in China, up to 10% of inpatients developed subsequent PE or DVT after presenting with COVID-19. With regards to current testing methods, all patients who are admitted get swabbed for PCR, and it's worth bearing in mind that this is only positive in 70% of patients with COVID-19. So it's quite a high false negative rate, and there's a potential that we're missing a big percentage of patients from the overall statistics of COVID-19. And I think our take-home message from our experience is if the clinical picture fits with COVID-19, then they should be treated as such unless an alternative diagnosis is established. And this is important in inpatients, as some patients may test negative, and the risk is then the patient being moved to another part of the hospital when in fact they do have COVID-19 and then subsequently test positive. And finally, I'll just finish the talk by talking about cardiopulmonary resuscitation, or what's known as code blue in some countries. And the UK guidelines are that in patients with suspected or confirmed COVID-19, chest compressions are to be avoided until the resuscitation team are in full protective equipment. What should occur is that the first responder who first sees the patient in having a cardiac arrest, they should call for help, and if there is definitely no cardiac output by feeling for a central pulse only, then defibrillator pads should be placed on the patient, and at least up to 3 DC cardioversions should be given if the patient is in a shockable rhythm, i.e. in VF or VT. The other important thing to note is that listening or feeling for breath sound is to be avoided. The only way now to check if the patient is in a cardiac arrest is to check for a central pulse. And again, both of these considerations, avoiding chest compressions and avoiding feeling for breath sounds, is to prevent aerosols being spread in the room or the bay without staff being in full protective equipment. Once full protective equipment is put on in the form of gowns, the right mask and gloves, then CPR should be commenced. And this is just illustrating that looking or listening for breath sound should be avoided because of the proximity to a patient's mouth. And here is the link I've provided showing an example of cardiac arrest in patients with confirmed or suspected COVID-19 patients in order to try and avoid infecting staff members in the process of resuscitation.